You're listening to the Move to Value podcast, powered by Chess Health Solutions. The Move to Value podcast is dedicated to helping healthcare providers understand and make the transition into value-based care. We do this through conversations and the sharing of innovative ideas with practitioners, experts, and leaders throughout the healthcare industry. Our mission is to sustainably transform the healthcare experience for the patient, provider, and care team by cultivating a value-oriented, compassionate, and health-aligned community. In this episode, Chess Vice President of Value-Based Operations, Josh Vire, talks with Wilson Gabbard, Vice President of Quality and Condition Management at Advocate Health, about how to gather and present meaningful data to providers in an easy and accessible way, which enhances their delivery of better patient care.
Well, Wilson Gabbard, thank you for joining us on the Move to Value podcast.
Thanks, Josh. Thanks for having me. It's good to be here.
Great. Wilson, I know you have a wealth of knowledge, both population health and value-based care. Can you just start by giving our audience an overview, a little bit about you, your background, where you've been, what you're up to today, and your responsibilities at Advocate Health?
Yeah, absolutely. Well, again, Josh, good to be here. Value our friends and colleagues at Chess and have long followed all the great work that you all have done. And so it's a privilege to be here again. By way of background, I'm a former practice operator. Used to lead clinic operations in Eastern North Carolina and had the privilege of kind of pivoting into a population health focused role back in 2013. So over a decade ago now, helping build out some of this work in a prior life. And over the years, it's been really interesting to see the evolution of value and how we've gone to taking on more risk and building out more sophisticated programs and blending together Medicare Advantage and MSSP or different value-based programs together to ultimately really just better serve the patients and clinicians that were really just privileged to be able to serve on a daily basis. So, today what I'm up to is here at Advocate Health, I have the pleasure of leading quality and condition management efforts as part of our enterprise population health structure. We think about value-based work and kind of a formulaic equation that is driven based on three main components, which are quality, utilization, and premium in lives. And how we do that, how we operationalize that is really around the two functions that I, again, have the privilege of kind of serving in or related to the quality and condition management work. And have the, again, opportunity to do that along a really amazing physician dyad who I feel very privileged to work alongside as we implement some of these programs.
That's great, Wilson. Thanks for that background, and glad to share that with the audience. As you mentioned, you've been at this for a while. You're very well versed on what drives and improves contracts in value-based care. So, really excited about again having you here. And could you go a little bit layer deeper in what is condition management and documentation? What does that mean specifically at Advocate, and a little bit about how your role plays in supporting value-based care efforts?
Yeah, great question. I think that our approach to value, and again, I think value-based care as, the corollary or antithesis maybe is the wrong word, but to fee-for-service, right? As we move from fee-for-service to value, we think about the premium in lives component that I mentioned earlier about ensuring that we are receiving the appropriate reimbursement for the patients that we're caring for. And the way that CMS, our government programs, have implemented that financial model and value is through a risk-adjusted payment mechanism. But at the end of the day, the way that we think about risk adjustment here at Advocate is that risk adjustment really at its core is just a population health fundamental that ensures it's all about ensuring that patients and their conditions are not lost to care. In value-based care, I love that the focus is not about on widget counting, but rather on caring for conditions, ensuring that those conditions have treatment plans in place for them. So really, that's what it means to us when we talk about condition management and documentation, is really what are we doing to ensure that we have care plans for patients' conditions, that they are persistently engaged with their primary care clinicians. And we think that that also has a huge driver in the utilization component. If we manage conditions proactively versus reactively, we can help avoid bad outcomes for those patients and help them stay in their homes where they prefer to be with their families.
Yeah, that's great, Wilson. You said some things that I really enjoy hearing. As we both know, and as I've learned and been working with you more, I'm learning about how Advocate and your team thinks about risk adjustment. And while we may or may not like how it's set up, it is the mechanism which we can accurately identify the health of the patient, and that is where the focus should be. And I've seen that from your team, that's what you guys focus on, is really about making sure that patient's getting the right level of care and that their conditions are accurately documented. And it's an important part of value-based care. And I know, in support of that, data is extremely important. I'm sure you will agree. Can you talk a little bit, how important is data to what your team does, and how do you work with providers to address these areas of opportunity?
Oh gosh, data is just so critically important, and the implications of ensuring completeness and accuracy of your data is just so important. And it's, both in kind of our condition management space, but also in our quality space. I think that the data is important to translate. Different audiences translate the way that they think about data differently, what resonates with them. And I ultimately think about storytelling. What's the story that we're trying to tell with the data that we have? The story that we might tell to a group of executives or an ACO board is probably different than the story we want to tell with the data to an individual clinician. And the reason I say that is, again, if even in quality, if we're just talking about quality from the perspective of hitting a number or getting to a goal, that's one story. But if we talk about it in terms of the patients whose lives are impacted by ensuring highly reliable, high quality care, that's a very different story. And, the number of cases of colon cancer that are likely to be present in our population that we haven't screened. Again, I found personally that those stories, that data resonates differently with clinicians whenever you're able to tell it in that way. And so I think that I hit on some of that, is that I think that leads into why getting data right and ensuring that we've got, again, completeness and accuracy in that data is so key. Because if you put data in front of a clinician that is incomplete, and there's always some level of incompleteness to a data set, but we have to avoid causing ourselves credibility issues in terms of the data that we're presenting. And, if you put a bunch of data in front of a clinician and they can poke tons of holes in it, you've lost your audience, because then you're talking more about the data versus the operation that we're working to transform. And so I also feel passionately, as a former practice operator, that we don't want our clinicians or care teams and clinics to be abstractors of data, right? We want to clean that up on their behalf. We want to ensure that we're going to where, the source of truth is, and curating that data for them to make it easy for them to do the right thing for the right patient at the right time. And so we've invested a lot of time and energy in going about getting that data from different EMR vendors through our ECQM efforts, and even through just different data exchange interfaces with our EMR vendor and different folks who use that same platform.
Yeah, that's great, and I love the focus on making it as easy and as accessible as possible to the provider to be able to help them to do the right thing, and not putting the onus on them to have to extract that data. That resonates, and one of the things I love about how you guys approach this work. So, Advocate for many years has been engaged in value-based care. I know you guys hold lots of different contracts, lots of different payers. As you know, every contract has different measures, particularly on the quality side. It's hard to manage and prioritize those. Can you talk a little bit about your approach and how you guys think about managing and prioritizing all the different quality measures across your various contracts with payers?
Oh, Josh, I mean, you know this probably as well as anyone, and the breadth and depth of what Chess has done to support your value partners in doing this work too. Again, it's something I've followed for a long time and learned best practices from. But, you know, I think about, we started a process a few years ago to get more granular in the way that we do this. And I think that it follows a process that's been long in place that helps us look at kind of several different areas in value-based contracts of what measures we want to prioritize, for example. We follow this rubric where we look at the alignment of the measures we select and we prioritize in alignment with the various, you mentioned, I think we have 108 value-based contracts across that portfolio of 108 value-based contracts. So that's kind of pillar number one. Pillar two is the population health impact of the measure. So for example, a measure, and I probably shouldn't pick on one specifically, but I will, osteoporosis management impacts so many fewer members and lives, not that it is not an important measure for the people that it impacts, than a measure like colorectal cancer screening. The population health impact is just significantly more pronounced in measures that impact broader populations. So that's kind of pillar number two. And then pillar number three is really how we think about performance. If we are like knocking it out of the park, 10 out of 10 for a specific measure, maybe that's a measure we shouldn't kind of lift to the top in terms of improvement. We are constantly, Advocate Health's pledge is to promote clinical preeminence and safety for the members that, again, we're privileged to serve. And so we are constantly looking at how are we getting to that top decile. And if we are at the top decile for a specific measure or measure set, you know, that's going to be one that we maybe take our foot off the gas on in terms of the prioritization so that we can focus on the areas that we have more opportunity for improvement.
Yeah, that's great. I was just taking notes here. I love the rubric you guys have built and how you think about prioritizing those across 108 value-based contracts is just unbelievable. I knew it was a lot. I don't think I knew that number, so I learned something. So that's amazing.
I should also call out there, Josh, we are privileged to have a really wonderful and sophisticated, this is obviously not me, but I'm privileged to have a really wonderful quality team across our footprint that really helps bring all this together in this thoughtful way. I wish I could even claim that this was my idea, but it wasn't. So we have fantastic leaders on our team that have helped pull that together.
Yeah, I know you guys do, having met many of them. So I want to talk a little bit about, yeah, it certainly takes a team of people to do this right and to perform well. And obviously, clinicians on the front line are an extremely important part of this. You've talked a little bit about how you guys help them to prioritize and where to focus and doing the heavy lifting on the back end. But what does your team think about, how do your team think about clinical engagement, and what have you all seen or done that you think works well that others might be able to learn from?
Yeah, I think I mentioned this already, but I think at the end of the day, we try to tie all the work that we're doing back to transforming the operation. You know, kind of like the old adage, you know, teach a man to fish versus feeding him a fish. We really want to kind of bridge that gap of there are things that we can enable for clinicians and care teams to do. But there are also things where we want to, activate their operational model to accomplish these value-based outcomes that we're driving at. And so, again, very fortunate to have some fantastic partners in this space, a really strong team of physician leaders, medical directors, and value-based performance teams. But across all of our teams who are working in this space, again, quality, CMD, value-based performance, we're all focused, I think, on trying to have a primary relationship management contact with that clinic and ensuring that they have one person to go to, more or less, right? And then complementing that team with subject matter experts who can be the phone a friend when things go deep, maybe in a clinical coding question about, what does this diagnosis mean versus that one? And do these things, do you have to do both of them or one of them? Or what's the correct coding guidelines? Or what's the exclusion criteria for a statin measure when a patient has an intolerance? What do I have to document? And so having those kind of broad level tools that can be deployed through relationship management resources that then have kind of phone a friend, kind of deep subject matter expertise with performance improvement focused expertise that can support them. I think that that's really our goal, to kind of transform, again, the operation and support those clinicians and care teams of delivering the care while the patients are in front of them.
Well, Wilson, this has been a great conversation. I'd love to dig in a little bit deeper and ask you a few more questions. Would you be able to stick around a little bit longer?
Yes, of course. I'd be happy to do so.
This is the Move to Value podcast, powered by Chess Health Solutions. We hope you have enjoyed this episode. If you would like more information about this and other episodes, you can head over to movetovaluepodcast.com to check out all of the available resources. If you're interested in continuing to hear about value-based care and how it impacts you, you can sign up for our email notifications or subscribe to this podcast on your favorite podcasting platform. Also, we would love it if you would share the Move to Value podcast across your networks and leave a rating or review. Thanks for listening.